Thanks a lot for a really enlightening talk. Now it's my deep honor to introduce Professor Dr. Clark Sebrechts for his undoubtedly very interesting talk about fenestrated FEVAR in octogenarians.
Well, thank you, Mr. Chairman, and thank you for the kind invitation to come to this wonderful meeting and also to have a chance to see Alexandria, which is actually the first time for me. So I'd like to start off with this talk focusing on octogenarians who have their treatment for complex aneurysms and that are treated with FEVAR. My disclosures. Well, what you see here is the aging of the European and the African populations. In 1960, just a small percentage was older than 65, but if we have a look at what are the estimates for the years to come, well, you can see that everything is becoming a lot darker, and darker stands for old. So it is to be expected that much more octogenarians with aneurysms will be admitted for further care in the future. And as you can see, these figures also apply for Northern African countries. On the other hand, normal life expectancy within this cohort of patients is obviously limited, as you can see on the left, and as a consequence, the expected profits of treatment should be carefully balanced against the expected quality of the remaining life years to go. Now we know that even the life expectancy of octogenarians increases after aneurysm repair. This patient population is highly susceptible to postoperative complications, especially after open repair. But with the introduction of FEVAR, they can be offered a much less invasive treatment, making FEVAR the preferred treatment in this vulnerable group. But the advantage of FEVAR or BVAR is actually less clear. So what we did, we gathered data from 2 tertiary referral centers in our country from all patients treated for complex AAA with FEVAR between 2001 and 2016, and we made a comparison for perioperative outcome as well as patient reintervention-free survival. We did this for 2 groups, those 80 years and older and those younger than 80. No real differences in baseline and aneurysm characteristics, although renal function was a little worse in octogenarians. 255 were treated with the Zenit and 17 with the fenestrated anaconda, accounting for a total of almost 90 fenestrations in the older group and about 527 in the younger group. When we look at the intra-operative results, there were no significant differences between the 2 groups regarding primary and primary assisted technical success. Also, number of endoleaks and number of adjunctive procedures were basically the same. And here you can see 30-day morbidity and mortality. One older patient already in a poor cardiac condition died because of a rupture of a renal artery and subsequent bleeding. And then also 7 younger patients died, 5 because of mesenteric ischemia, 4 of them with occlusions of the SMA and or celiac trunk, and 2 died because of myocardial infarction. Well, what is interesting to see is that with similar median follow-ups, there were no significant differences between the groups for estimated cumulative patient survival, although I have to admit that there was a tendency, but at 3 years the numbers were quite small. And if we look at the causes of death, in both groups they were very heterogeneous, with cardiac-related deaths as the primary cause, and luckily few aneurysm-related deaths, of which most of them had a problem that was treated conservatively with death as a result. Complications and reinterventions, they varied, and they included mostly treatment of type 1A and 3 endoleaks, thrombectomies and thrombolysis, and stenting of stenosed and occluded aortic side branches or excess vessels. And there was no difference between the groups for estimated reintervention-free survival at 1, 3, and 5 years. And the same account for target vessel patency, 3.4% in the older group, 5.4% target vessel occlusions in the younger group, but not significantly different. Then in the older group, the mean estimated GFR remained stable at around 60, but in the younger group, a significant decline was seen both postoperatively and even more so at the latest follow-up, and 5 people became dialysis dependent and none in the older group. Now, we're not the first one to publish about this subject. There are actually 3 interesting papers that maybe should be mentioned. The first one is from Lille and Malmö. They also gathered their data, and although mortality at 30 days differed significantly, this was not the case at midterm, and was therefore felt that FEVAR should be considered as a considerable option also in octogenarians. Timmerang came with the same conclusion. What they saw was that there was a reintervention-free survival of 90% in octogenarians at 20 months, but a 43% rate in the younger group. And that's a remarkable difference, but a very small sample size, and I rather believe that age doesn't really influence aneurysm or endograft-related reintervention rate. And then the Hamburg group from Germany, they did a retrospective comparison of their recent FEVAR and VIVAR cases, and they found that early all-cause mortality was higher with octogenarians, and in their multivariate analysis, after predictors for early all-cause mortality, age higher than 80 years was an independent predictor, and within this group, those with ASAR class 4 or 5, or those that came in with a rupture, they were not surprising, of course, at the highest risk. Well, I'm going to jump this one. So in conclusion, ladies and gentlemen, I believe that age itself is not a reason to withhold FEVAR in the elderly.
Dear doctor, your time is up.
Should be actually based on the patient's comorbidities and preferences. I think I'm done. So thank you for your attention.